All right, hopefully that works. So just hope to cover a few topics today, starting off with how we think about identifying and classifying implementation strategies. And then I'm going to talk a little bit about how we can better develop and tailor implementation strategies to fit the needs of specific interventions and contexts. And then I'm going to conclude by sort of emphasizing the importance of specifying and testing mechanisms of change in implementation science, and of tracking and reporting implementation strategies. And hopefully we'll have some time for discussion. If not, happy to follow up afterwards. So just to sort of level set for everyone, we've talked about implementation strategies in our work as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. Obviously, these programs or practices vary quite a bit, and admittedly, I don't have a ton of experience in the mHealth world, so you'll have to bear with me on some of these examples, but glad to be here nonetheless. We often talk in our work about discrete implementation strategies, which involve a single action or process. So things like clinical reminders in an EHR, audit and feedback, wherein we may measure performance of providers or others and feed it back to them, oftentimes in comparison to their peers, or something like clinical supervision in mental health as quote unquote discrete or single component implementation strategies. Now, admittedly, these so-called discrete strategies are complex interventions in and of themselves, and can be operationalized a lot of different ways, and different operationalizations of these strategies can certainly influence whether or not they are effective. And so sometimes it feels like a bit of a misnomer to call them discrete. But nevertheless, oftentimes in implementation, we have a need for multifaceted strategies, sometimes even that are multi-level. You may see the term sort of implementation interventions or implementation bundles to describe what is essentially a combination of multiple discrete strategies, hopefully that are designed in a way that are such that they are targeting implementation determinants or barriers and facilitators to change in a thoughtful and coherent way. Just to give you some examples, both of discrete strategies and sort of the alignment that we would like to see between the challenges that we face, the barriers and facilitators or determinants, the strategies we're using, and the types of outcomes that we would like to see. Just a couple examples here. If we have a provider skill deficit, obviously it may be that training or teaching and practice with corrective feedback would be an intuitive implementation strategy to use, that may operate through the mechanisms of skill acquisition, refinement, and mastery, and be plausibly linked to something like fidelity to an evidence-based practice, right? At slightly a different level, turnover is a huge problem in healthcare and social services. A strategy like train the trainer may operate through the mechanism of ensuring that real-time training and consultation is available, and be plausibly linked to an implementation outcome like sustainment. And I won't go over each of these, but again, the idea here is that hopefully we see a tight alignment between the types of strategies that we are using, the types of barriers we're addressing, and the types of outcomes we're trying to achieve. Just to give you a quick example of this, and this is not perfect, but this is, I think, a really nice paper from my colleague Sam Schilling, who is a primary care doc and a child maltreatment pediatrician. And Sam has been involved with an evidence-based child maltreatment prevention intervention in primary care called PriCare. And though this might not be sort of our typical implementation outcome, she was really struggling with actually how do we get physicians to refer to this PriCare intervention. That was sort of the linchpin of this evidence-based practice. And what you see here in rectangles are the implementation strategies. And so she used a variety of implementation strategies using this sort of multi-level heuristic. So she used public recognition by providing physicians small forms of recognition, like a $5 Starbucks gift card for referring patients to primary care. She presented parent narratives, so parents who had gone through the intervention and could speak to its usefulness. And she sort of hypothesized that those two strategies would work in an accumulative fashion to address clinician motivation to refer to primary care. She also used an audit and feedback strategy where she assessed referral patterns and fed that back to physicians in comparison to their peers, which she thought would, amplify the effect of those strategies on clinician motivation. She also prepared parents to be active participants. So she engaged potential clients with a MyChart notification that described the intervention and hopefully improved their motivation to ask about the primary care intervention. She assumed that improving clinician motivation and parent motivation would improve the parent-clinician interaction and increase discussion about the primary care intervention, that those two factors would sort of converge to improve that. And then finally, she used clinician reminders in the EMR to facilitate the effect of these strategies on referrals to primary care. And she showed using, this wasn't an RCT, this is really a relatively simple quality improvement design, but showed that she was able to improve referrals from 13% to 55%. The other reason why I highlight this paper is I think she does a really nice job of talking about sort of the theoretical and empirical justification for each strategy and describing how they are obviously intended to work together in a synergistic fashion to improve referrals. And so I would urge you to take a look at both of those papers referenced here if you have interest. So as we think about implementation strategies, one of the challenges in the literature is that they're often described in wildly different ways. So sometimes the same term is used to describe very different strategies, or different terms are used to describe what's essentially seems like the same strategy. And there's a lot of inconsistency. And so some of the work that we've done is actually to develop and refine a compilation of implementation strategies or taxonomy of implementation strategies. I'm not going to dwell on this too much in terms of the particulars, but what you see here is the expert recommendations for implementing change compilation or ERIC compilation. I'll point you to additional file 6 of the paper referenced below for perhaps the most sort of comprehensive description of these strategies. But what we were trying to do here is simply name and define implementation strategies in an effort to really provide folks with a tool that would help them to identify building blocks of multi-level, multifaceted strategies for research and practice. And we were also trying to address this language issue in the field by promoting a common language and improving reporting in the field of implementation science. I'm not going to go into sort of the origins of that and the methods, but just to note, there's plenty of room for critique, dialogue, and ongoing refinement. I often quote my colleague Kate Livero at Columbia, who says, as we think about frameworks and tools in the field of implementation science, tools, not rules. So don't feel constrained by these things, but hopefully they can provide a useful resource for your work. And I'm going to give several examples of folks that have actually worked to refine this compilation of implementation strategies, and I think improved its utility over time. One such group is Sherry Rogal and Vera Yakovchenko and colleagues at the University of Pittsburgh, who have actually turned this ERIC compilation into a survey that they've used to longitudinally assess implementation strategy use in national implementation efforts in the VA and elsewhere. Sherry is continuing to work to refine that survey and increase the utility of the compilation in that way. She's also used innovative methods, and so just to quickly highlight the two papers on the bottom right-hand corner of this slide represent efforts to use configurational comparative methods, which are really born out of this idea that there's more than one way to be successful and achieve our outcomes of interest. And so these methods help us to identify, in this case, implementation strategies that are both necessary and sufficient to achieve our implementation or clinical outcomes of interest. And so I think they represent really interesting methods papers if you have a chance to take a look, and if you think that might be relevant to your work. So we talk a lot about implementation strategies. What are the things that we need to do to get people to use new practices, adopt and implement new practices? Some of the questions we've asked also have been focused on sort of are those same strategies equally useful for sustaining interventions, or scaling up interventions, or de-implementing interventions? So how do we get people to stop doing things that are either no longer effective or are potentially harmful? And so these papers represent an effort to apply the ERIC compilation to these questions. And the paper on the left by Nicole Nathan and colleagues in Australia, I think is useful in that it specifies the specific phases in which you might consider those 73 ERIC implementation strategies, and so could be useful in informing your work. The paper on the right, I think, largely demonstrated that a lot of these strategies are equally relevant and can be used to categorize de-implementation strategies, or to prospectively select de-implementation strategies that are relevant to your work. I didn't talk a lot about the origins of this compilation, but one critique is that we were very U.S.-centric in the development of this compilation initially, and so there have been fair questions about how do these strategies apply internationally, and might other strategies apply? And so Kate Lavera, who I mentioned previously from Columbia, has led a systematic review of the use of this compilation in low and middle income countries, and found increasing use of the ERIC compilation. Also, I think in that review identified, potentially some other strategies that aren't well represented. Similarly, Ingrid Eschen-Wilson and Elvin Gang and colleagues have conducted a living analysis of HIV implementation science in LMICs, and found that in particular, patient-focused implementation strategies were not well represented in the ERIC compilation, which frankly was not a surprise to me, given the way we developed that taxonomy. But so this is just to say that, again, you shouldn't feel constrained by these tools or taxonomies of implementation strategies, but hopefully they can be a tool in your work. We're also seeing, a number of translations of this work into other languages, German, Spanish, and Japanese, and perhaps others. And so hopefully we'll continue to sort of pressure test this over time, and hopefully enhance its utility to inform implementation research and practice. And then just very quickly, Dr. Spring mentioned behavior change techniques, and I believe was referring to those sort of represented in this behavior change technique taxonomy by Susan Mickey and colleagues at University College London. But one of the questions we've asked, these are sort of the ingredients of interventions that are described at a bit more of a granular level than we've described our implementation strategies in the ERIC compilation. And we actually see utility in combining these, that they're actually complementary. So just as an example, we may have an audit and feedback strategy or an educational workshop, and it can be useful to specify the specific behavior change techniques that are at play within those given implementation strategies. And so the paper in the middle by Sheena McHugh at University College Cork represents an effort to sort of link those compilations. I also represent at the bottom of this slide some of that emerging work from Dr. Mickey and her colleagues through the Human Behavior Change Project, which, if you're not familiar, there's an enormous body of work that they're taking on through that, and I think highly relevant to this group if you want to spend some time digging into that. So I'm not going to talk a ton about the evidence for effectiveness of implementation strategies, but just to say that we have a growing body of evidence. For instance, the review for audit and feedback, the Cochrane review for audit and feedback was just updated, and I think they have nearly 300 RCTs now included in that audit and feedback review. We just updated the tailored interventions for or tailored implementation strategies Cochrane review, and similarly found, I think, maybe close to 3 times as many RCTs as were previously included. And so we see a lot more evidence for implementation strategies, although not all of it is always so rosy. So you can see here, this is very meta. This is 86 systematic reviews of different types of strategies. So it's a review of reviews that found small to moderate effects of implementation strategies, mainly on processes of care. They noted that while context is key, a lot of these reviews don't necessarily, or original studies don't necessarily adequately account for context or explain its role in implementation. And they conclude by saying what is needed isn't more reviews or reviews of reviews, but really research to explore the situated, relational, and organizational nature of evidence-informed practice. And I'll get into that a bit. I think this really speaks to a need to understand what works under what conditions and for whom. This has got to be overwhelming to you, this figure here. But I wanted to include this paper by Singh and colleagues who were looking at, they conducted a realist review of the literature to really ask questions about how pay-for-performance programs work in LMICs. And one of the things that I really liked about this paper, they used causal loop diagrams. This was a system science-based method here to represent essentially an initial theory of change and a revised theory of change based on the empirical literature. And so they represent sort of their initial theory, as well as in the green here, the pathways that are common to both their initial theory and the revised theory after the review. But this gets both into sort of the complexity of how implementation strategies work, but also the importance of being quite explicit about our theories of how implementation strategies work, or as I'll talk about towards the tail end of this presentation, the mechanisms through which implementation strategies work. So I think a really nice example of sort of the iterative nature of theorizing and empirical development that is needed in the field. So moving into sort of how we can think about designing and tailoring implementation strategies, and forgive me if you've seen some version of this before. I've been including this slide for a long time now, so it's old to me, hopefully not completely old to you, but we see a lot of potential pitfalls in designing implementation strategies. And one of the things that we see is that we use sort of the train and pray or train and hope approach, right? We send people to trainings, we hope that their behavior changes. We know that that's sort of necessary, but not sufficient to change behavior. We also see a number of other things. You run into sort of organizational inertia. Sort of we've always done it this way, and this takes a lot of different forms. And so, I've often referenced hearing from folks that sometimes healthcare administrators, their favorite implementation strategy is sending an email in the morning and expecting that implementation will happen. We also see folks that always use learning collaboratives, always use plan, do, study, act cycles, or other implementation strategies that they've found helpful, but maybe not necessarily well matched to the current needs of the situation. We also see a sort of this notion of a kitchen sink approach, or this idea that more is better. More complex or more intensive implementation strategies are more effective, when in fact, empirically from reviews, we know that this isn't necessarily true, that simply adding components to an intervention or an implementation strategy doesn't necessarily make it more effective. This is a little bit counterintuitive as we think about the variety of barriers that we face in the field, but it could be that multifaceted strategies are not well matched to those barriers or implementation determinants. It's also often the case that perhaps a multifaceted strategy might be sort of targeted at a single level. So you might have multiple strategies that are really targeting the provider level, but neglect sort of patient level factors, organizational level factors, or even systemic or policy level factors that might be influencing implementation. Um, I'll also just say that an emerging concern in the field of implementation science is that we may be recreating the problem that we're trying to solve by developing sort of clunky interventions that are too expensive, that aren't necessarily feasible. And again, I think Dr. Spring highlighted this well in the sense of, like, if you have a chance to do a trial, you want it to be successful. You want to, potentially you want to develop an implementation strategy that's going to be robust. But in our efforts to do that, we have sometimes perhaps sacrificed pragmatic properties of implementation strategies to our detriment. So again, I think probably highlights the importance of most and optimization strategies, both for interventions and for implementation strategies. So this is arguable and a bit of a messy area in the field, but one might argue that we often are too often using a one-size-fits-all approach in implementation. That we need to use strategies, again, that are more adaptive to the needs of our implementing partners, whether that's individuals, teams, organizations. That for instance, organizations that need less support receive less support, whereas those that receive need much more intensive supports receive the support that they need. And finally, in implementation, it's sort of joke that we often use the Aslagiata principle, or it seemed like a good idea at the time. We're not necessarily thinking systematically about the implementation strategies that we're using, and therefore not as likely to be successful in our efforts. Dr. Spring talked a lot about alignment in different ways, and we see issues with alignment even in our implementation efforts. As Michelle Vensing and Richard Grohl have noted, there's often little association between the types of problems that we face in implementation science and the types of implementation strategies or approaches to change that we use to address them. So, for example, organizational and system-related problems are often detected, but they tend to be either ignored or when they are detected, we often use individual educational and psychological approaches, perhaps because they are more feasible or more familiar to us. But this sort of misalignment is obviously problematic for our field. So we've tried to advance in our work the notion that improving the impact of implementation strategies will really necessitate that we enhance methods for designing and tailoring implementation strategies, that we begin to think and be more explicit about specifying and testing mechanisms of change for implementation strategies, and that we improve tracking and reporting of implementation strategies such that we improve the transparency of how we're implementing things and how implementation efforts were successful or failed and need to be adjusted. I won't mention today sort of the importance of implementation trials and conducting economic evaluations, but those are also major priorities that we've identified over the years. Now, I think this will be quite familiar and maybe intuitive to folks, but just to say, I guess to foreshadow, there are a number of systematic approaches for developing implementation strategies that are being proposed, that are being developed. I think all useful in their own way, and I think a positive sign for the field. They also share a lot of things in common, and so these are just basic sort of steps to developing a theory-informed implementation strategy or intervention. Again, I think this sort of cuts across intervention development more broadly. But the first step is really to identify who needs to do what differently in order for implementation to be improved, or sustainment, scale up, et cetera, to be improved. And I think here we often don't think broadly enough. We might be thinking about specifically who's delivering an intervention or who's receiving an intervention, but really thinking broadly about who needs to be at the table, who's affecting implementation and who's affected by implementation, and how can they inform our implementation efforts, and how does their sort of how do people's behavior need to change at multiple levels. We then can use informal and formal theories and frameworks to identify barriers and enablers that need to be resolved, and hopefully articulate a pathway of change for the targeted behavior change to occur. And I'll just note here that a variety of research methods can be used. At this point, we have a lot of studies documenting barriers to implementing various interventions. So a literature review is often a good start. Certainly, we can collect quantitative, qualitative, and mixed methods data about this, or even engage in more sort of informal consultation with implementing partners. I'm a journal editor, and we get a lot of articles that are sort of regurgitating, barriers and facilitators in different areas, and oftentimes those studies are not very exciting and don't necessarily advance the field of implementation. And so perhaps we can talk about ways to sort of push that work forward and generate a better understanding of implementation determinants. The third step is really selecting implementation strategies, and this is inclusive of the behavior change techniques that Dr. Spring mentioned, and modes of delivery that might be effective, locally relevant, acceptable, and feasible to overcome barriers and enhance facilitators to change. And then lastly, how can change and implementation be robustly and feasibly measured? So this includes thinking about sort of the more proximal, intermediate, and distal outcomes, or the implementation outcomes and perhaps clinical outcomes that we would like to see change, but also the factors along the hypothesized causal pathway. So potential mediators, moderators that need to be specified and measured, which we'll talk more about. I won't dwell on this slide, but just to say, this is a colleague, Shoba at Harvard, who's I think written a really nice paper on integrating participatory implementation science approaches throughout the process. So as we think about, even considering evidence and local priorities to select an evidence-based intervention, considering and assessing implementation determinants, choosing or developing and refining implementation strategies, considering mechanisms and considering the outcomes that we're assessing. I think best to be participatory throughout this process to the extent that we can, and to the extent that you have appropriate partners at the table. I think our efforts will be improved. And so can't recommend this paper highly enough, and hope you'll have a chance to take a look. I also won't dwell on this slide, just to say some of these papers are quite old now, but we're really trying to say, what are the methods we can use to design and tailor implementation strategies? And I'm going to present a couple examples of this, but again, this is mainly meant to suggest that there are a lot this is 8 years ago now, but already there were a number of potentially a number of systematic methods that we could potentially use to design or tailor implementation strategies. And so if you're proposing this in grant-funded work, there are frameworks or process models that you can use that will provide some structure for sort of how you're developing and tailoring implementation strategies. And I think your efforts will be improved by doing so. So one really, I think, common and increasingly used method is intervention mapping, or implementation mapping, as it's been sort of defined and recast in the implementation science space, to develop implementation strategies or to adapt interventions. And I won't go over the specific steps here, because I think they're basically identical to or very similar to the steps for designing theory-informed implementation strategies that I went over on a previous slide. But just to say, we've been using this approach a lot, and we've used it in a couple of different ways. In the study in the middle, we actually use this to sort of co-create implementation strategies with organizational leaders and clinicians. And this is based on the need that, based on the premise that organizations have different strengths and needs, that their implementation efforts really would benefit from an implementation strategy or plan that's tailored to those needs. And so we actually went through the steps of this process in collaboration with those partners to develop site-specific implementation plans. More commonly, we've been using intervention mapping or implementation mapping when we have some idea of the implementation strategy we might want to use in a larger trial. So for instance, the trial on the right represents an effort to implement a systems navigation and psychosocial counseling program in Vietnam, really to scale up that intervention. And we used implementation mapping to develop a tailored implementation condition, wherein organizations had access to basically a menu of implementation strategies that they could tailor to their site-specific needs, and then a more standard implementation condition. And the results of that study, I think, are still under review at Lancet Global Health. But we actually showed that we were able to, in the tailored condition, improve both implementation fidelity to the intervention, as well as viral suppression, one of our clinical outcomes in that trial. And again, intervention mapping or implementation mapping has been quite helpful in giving reviewers a sense that even though we may not have our implementation strategy completely locked in as we propose a implementation trial, we have a structured process that we can use to refine or develop that in the formative phases of an R01, for instance. These are sort of similar steps, and I won't belabor this, but wanted to point out this paper from Terrence Swindle and colleagues at University of Arkansas for Medical Sciences, where Jeff Curran, who's one of the sort of original authors of the hybrid effectiveness implementation study paper and subsequent papers, have really developed an evidence-based quality improvement approach that goes through sort of similar steps as an intervention mapping. But what I like to point out as I show this paper is that the actual activities that you use to accomplish each of these steps, hopefully you can see this, are quite varied. And so I think they vary in terms of their level of rigor, perhaps the extent to which they might fit your particular implementing partners. And so I think there's room for creativity here. There's room for testing different methods and really innovating and establishing the literature in this area as we think about systematic approaches. Just a couple more examples, or maybe one more. Dr. Spring mentioned the Consolidated Framework for Implementation Research, which is a common framework for identifying implementation determinants. And one of the tools that we've created is a matching tool that allows you to identify a sort of a CFIR defined implementation determinant, and then identify the types of implementation strategies that might be useful for addressing that. So, for example, if you have low reflecting and evaluating, there's little or no quantitative or qualitative feedback about the progress and quality of implementation. You may want to use strategies like developing and implementing tools for quality monitoring, audit and feedback, and a number of other potential recommendations that were seeded by an expert survey. And you can see that tool here at the link on the CFIR Guide website, as well as the paper by Tom Waltz and colleagues in 2019. More recently, Vera Yakovchenko, who I mentioned on a previous slide, and colleagues have actually shown that the results of this CFIR matching tool actually reflect well effectiveness findings in sort of quote unquote real world studies of implementation. So I've often wondered about sort of how well we did with these recommendations, as the experts suggested a wide range of implementation strategies for addressing even a single barrier. But there's some sort of face validity to this, and now some empirical evidence that the recommendations might not be terrible. There's also linked below a theory and a technique tool that's tied to the behavior change techniques that have been mentioned and the theoretical domains framework and the like. And so you can check that out as well if you have time and interest. Okay, I know we're not we're running a bit short on time, so I'll fly through some of this, but just to suggest that as we think about how and why implementation strategies work, we're increasingly focused on mechanisms of implementation strategies. And I note here, this may be an older link actually. In fact, it is. But the NIH D&I program announcements, or the program announcements for dissemination and implementation in health, have really emphasized the importance of understanding mediators, moderators, or implementation mechanisms in our studies. And so we think about mechanisms as processes or events through which our implementation strategies operate to affect desired implementation outcomes or other outcomes of interest. And Pedja Klasna, who's a faculty for this institute, has led a paper in implementation research and practice where he suggests a number of ways in which understanding mechanisms can really help us in the field. It first of all can help us to match implementation strategies to determinants. So I mentioned that as a key step in a lot of these processes, but it's often a little bit of guesswork to match strategies and determinants if we're not being clear about how and why it might address those determinants. So this can help make those links quite explicit. It can also help us to understand the conditions under which an implementation strategy will work. So identifying preconditions that must exist for the strategy to work, any moderators that might strengthen or weaken how well a strategy works, and really understanding some of those contextual factors. It can help us to design and optimize multifaceted implementation strategies. So again, we have this notion that perhaps our strategies are becoming too complex. Really thinking about the mechanisms through which implementation strategies work will help us to identify if we have unnecessary redundancies, if we have, for instance, multiple strategies that are unnecessarily addressing the same types of determinants, or if there are ways to streamline and sort of eliminate those redundancies. Ultimately, it makes our work less implicit. Usually, we always have some kind of implicit theory about why our implementation strategies work, but developing causal theories about how strategies work by explicitly specifying potential mechanisms is one way of making that explicit. It also helps us to measure strategy functioning. So we could potentially potentially identify earlier on in the implementation process whether or not a strategy is working if we understand the more proximal outcomes that we're trying to address, and whether we actually see changes in those factors. And then finally, as I'll illustrate, it can also help us to diagnose why an implementation strategy did not work as intended. So rather than sort of jettisoning a strategy that doesn't work, we might actually use mechanistic thinking to refine that strategy over time, or have a plausible explanation of why it didn't work in a given effort. So one example of this is from a paper we published in PLOS Medicine that was actually in response to an implementation trial of a strategy called knowledge brokering. And knowledge brokering in this case was being proposed to improve evidence-based staffing. And so, this top oval is representing sort of the effect or phenomenon of interest that knowledge brokering is supposed to improve evidence-based staffing. And essentially the trial produced null results, and so they said, okay, knowledge brokering not effective in improving evidence-based staffing. We looked at that paper and we said, well, why is that the case? And wouldn't it have been much more helpful if they actually specified the mechanisms through which knowledge brokering was supposed to work? So in this case, knowledge brokering is proposed to work potentially through cultivating a social link. So knowledge brokers, develop a relationship with, in this case, hospital managers. They provide brokered knowledge of the evidence. So they package, simplify, and contextualize the evidence for hospital managers. Hopefully, these managers absorb, understand, and integrate that knowledge, change staffing, and ultimately that leads to evidence-based staffing. There's also a component in which knowledge brokers facilitate individual and organizational capacity for change and increase managers' ability to sort of use and interpret this data. And I won't go over all of these contextual factors, but just to go over one that I think is informative. as we think about knowledge brokering, the status of the knowledge broker and the positioning of the knowledge broker within an organization is important. Sort of, do they have the relational capital that they need with hospital managers? Will they be sort of respected and listened to in this environment? And within this trial, they actually used a postdoc as a knowledge broker. And so one might argue that in this case, perhaps a postdoc might not have the sort of relational capital needed to provide brokered knowledge to hospital managers. And in fact, that may have led to the findings that they received in this, that they attained in this trial. And so specifying mechanisms in this case helps us to not only consider this contextual factor as we operationalize this strategy, it also might suggest that we want to measure things like the status of the broker and positioning of brokers within an organization if we're going to conduct empirical work on a strategy like this. So again, speaks to contextual factors and sort of where this might work and what might be sort of either moderating or even a precondition for the strategy working. I think for the sake of time, I'm not going to dwell on this a ton, but just to say we have a lot of work, and PEDGA has been huge in this work in terms of developing causal pathway diagramming. It's a specific approach to thinking about how and why implementation strategies work. There's a toolkit that we've produced from this work that's linked here that provides a lot of depth and breadth about developing these causal pathway diagrams if you're interested. And we've seen people do this to good effect within grant proposals and manuscripts and the like. But even if this is sort of back of the envelope or napkin, as it were, this is a helpful way of trying to make explicit how and why our implementation strategies are working. In an NCI-R01, we're producing causal pathway diagrams for 30 commonly used implementation strategies, developing measures of mechanisms, and ultimately we'll disseminate this knowledge on mechanisms through a database and website. So stay tuned there, and you can also see the Weiner et al. Paper at the bottom of this slide for an example of sort of our causal pathway diagrams or sort of middle range theories of how implementation strategies work. This is just to say there are a number of ways of representing this. This is actually from work by Lydia Kwak and colleagues at Karolinska in Sweden, wherein we actually, again, use mechanistic thinking to refine an implementation strategy that originally was found ineffective within a larger trial. And so they tried to redesign the implementation strategy, this time using the COMB framework and the theoretical domains framework to specify hypothesized mediators and to be quite explicit about how their implementation strategies were addressing those mediators and ultimately influencing their implementation about outcome of interest, which is fidelity to a guideline to improve mental health within school settings for teachers. So just other, I guess, alternative ways of being explicit about how and why implementation strategies work. I think a natural outgrowth of this work is to think about sort of the complex mechanisms at play in implementation strategies. And so we've used system science to illustrate how we can identify more complex mechanisms in implementation science. And I think a natural corollary here is also considering ripple effects or unintended consequences of implementation strategies. And so we know that implementation can lead to sort of negative unintended consequences, such as administrative burden, opportunity costs, or even things like data gaming or treatment counterfeiting. We also see positive unintended consequences like the use of evidence-based intervention strategies for self-care or with friends and families. But thinking about mechanisms, I think, can be a sort of natural lead-in to start, hopefully, though it sounds counterintuitive, anticipating ripple effects or unintended consequences in our work and monitoring that more carefully. Just very quickly, if any of you are interested in mechanisms and how we can advance this work, we've published from a AHRQ funded conference series, a research agenda to advance the study of implementation mechanisms. And I think this paper can be overwhelming, but it also, I see it as like a lot of different opportunities for investigators to contribute to this literature. I think it's going to take all of us. It's complex work and a bit daunting when we think about it from sort of an individual investigator standpoint. But I think a lot of opportunities to advance that work. And maybe just a couple more slides, and I'll shut up here. One is I noted the poor reporting in the field, that we have sort of poor reporting and tracking of implementation that limits replication in science and practice. Obviously, it's not unique to implementation science, but certainly implementation science is plagued by this problem as well, which precludes answers to how and why implementation strategies work. And so we've been advocating that people carefully name and define implementation strategies, hopefully in ways that are consistent with the prevailing literature. And things like the ERIC compilation or the behavior change techniques are one way of sort of ensuring that you're using language that's consistent. Again, don't necessarily be constrained by that, but hopefully those are helpful resources on that front. But more importantly, for each strategy that you're using, and this includes each discrete strategy that you're using, specifying things like who are the actors involved, what are the specific actions that they're taking, what is the action target, or you can think about conceptual targets of the strategy, or even the mechanisms through which it works. You can think about things like the timing or dose of the implementation strategy, the implementation outcomes, or more broadly, the proximal, intermediate, and distal outcomes that you're influencing. And then I think importantly, the empirical, theoretical, or pragmatic justification for the use of those implementation strategies. And we've also tried to advance work on how we can better track this in implementation trials or other applied implementation efforts. And this is just, won't dwell on this here, but just the notion that we should really, specify the strategies that we're using, but also we know that, stuff happens. COVID happens. A lot of other challenges to research happens. That may lead us at times, if it's allowable or unavoidable, to change the strategies that we're using. We may drop strategy components or add strategy components. And so really tracking and documenting that over time, using the structure of the aforementioned slide, I think is quite important. Just some design resources here if you have a moment to take a look. And I'll stop here, and hopefully we have at least a few minutes for discussion. And again, happy to follow up with you after the fact, and certainly hope our paths will cross elsewhere.
Thank you, Byron. Open it up to the scholars. Raise your hands. It's a little hard to keep track of all the participants, but please.
I put them to sleep, or they're ready for a break.
I think Madison has a question.
Yeah, I've always kind of had this question about it. It makes me think in a lot of like overlap with like the Matt Knock mechanisms of behavior change, kind of extending that to systems wide things. I did a T32 postdoc on mechanisms of behavior change, and I don't know if we've ever, in the 20 years that research has been going, like if a single mechanism has met all of the criteria to be called a mechanism. And so I'm kind of wondering, like, how do you branch that out to these kind of system-wide implementation things and like actually do studies to identify correctly those mechanisms?
Yeah, great question, Madison. So first of all, I think sort That's why I mentioned sort of on the research agenda slide, sort of how daunting this is. I think in implementation science in particular, for instance, I have a colleague, Nate Williams, who's done interesting work related to mechanisms, including sample size calculation for, multi-level mediators in implementation. And basically it's like, when I see that work, I'm like, there's no chance, right? Like, because usually the mechanisms are much more complex. It's pretty difficult to isolate and have a single study that's going to establish it. I mean, I think we see examples of efforts to do that are promising. But to your point, it's probably a long road, which is why I say it'll take all of us. And I think this might be unsatisfying, but my bent is actually more that like, even thinking about this like as a way of theorizing and using qualitative data to see how and why things are working is a step in the right direction. Because I'm like, I guess, more cynical that we'll be able to quantitatively, meet all those criteria and say this mechanism is sort of immutable across these contexts. So I'm more sold on the notion that it's even useful to try to specify mechanisms, and that it gets us to a more thoughtful place with the strategies we're using. Quite honestly, in that NCIR one that I mentioned, even amongst the study team, it's like we argue about what should be like we're just, I don't want to say we're just making it up, right? But we're using the literature as well as we can. We're trying to use sort of group processes to come up with these causal pathway diagrams. And we might not always agree, but I think we end up in a better place than if we just sort of, didn't think of it at all. And so I think a variety of methods need to be brought to bear to understand this. And over time, hopefully we have more of a consistent sense about what works and why.
Rose?
I'll jump in with a question. I thought it was really interesting talking about building the relationship capital of a person doing the implementation into the study, and how do you model that? It's so unique and individual, and yet you want a repeatable way to conduct everything. And so, are you in these situations? The people doing the implementation are sort of your participants, I guess. And so, but then how do you profile them? That's an interesting question.
Yeah, it's a great question. And I think sorry, I'm getting a little bit of an echo. That's but it's an interesting question, and it's actually come up in a variety of settings. So for instance, I used to be sort of peripherally involved in a organizational intervention, that had this really dynamic coach, and we always wondered, like, is this the Tony effect, or is this actually like the intervention that's effective? And I think in the implementation facilitation literature, they've wrestled with the same thing. Like, is it the characteristics of facilitators? And I think one way to address that is to think about like, as like Joanne Kirchner and others who have been involved with advancing facilitation as an implementation strategy, they've thought about, and Jeff Smith and others, they've thought about like, what are the factors that lead to sort of fidelity of that strategy, and also I think part of that has been identifying characteristics of facilitators. And so I think we can be quite explicit about that, and even to some extent train for those characteristics. And so maybe easier said than done, but I think that's that makes sense, that we would want facilitators with certain relational skills that are going to make or break whether or not that's effective.